This is the internal medicine training quality criteria launch. And for those that have got long memories, you'll recall that there was a previous launch of core medical training quality criteria, but that's now a decade ago. And I hadn't realized it was that long ago, but we will come back to that in a minute. So thank you very much to everybody for attending. That is how we're starting. I'm going to give a short talk about the background to the quality criteria. Then we'll be hearing from Sir Stephen and Professor Marion Bain. There will then be an interactive exercise where we'll get feedback and then a subsequent panel discussion about what we're hearing. And the two aspects we're going to be covering are quality, but also consistency and how we combine the two in terms of training. There are a large number of organisations that have come together to try and develop the quality criteria. We do not believe this is something that should be just delivered by the colleges, and the Federation has organised this event based on the three physicians' colleges, but it is critical that we have input from the GMC, from the SEBs, the statutory education bodies, NHS employers. We had lay representatives on the oversight group. We've had input. I'm hoping I saw Jeanette coming in, but from the, there you're right at the back. Jeanette Dixon is chair of the Academy of Medical Royal Colleges. Welcome, Jeanette. Medical education leaders. And of course, we have to ensure that we're engaging with the resident doctors as they are the future of the medical profession. So the background to the quality criteria, I've alluded to already that we developed the internal medicine training program starting in 2019. And this is there to develop the critical skills that are necessary to become a physician in the early stages of training. So managing the acute take, the dealing with general medical conditions. As they move through this, they should be becoming more capable and more confident. Of course, internal medicine training took over from core medical training, and I've alluded to the fact that the first quality criteria initiative came in 2015 and was sponsored and led by David Black, who I also thought was here. Yes, he is indeed. Alistair Miller and Miriam Armstrong, who's been critical to the development of the internal medicine quality criteria as well. Those initial quality criteria were then sponsored through to general internal medicine training and acute internal medicine training. That all happened in 2018, and we were looking to try and evolve the NTS, the National Training Survey, questions so that we could look to see how these would apply to internal medicine training. There was a bit of a hiccup in 2020. I think some people here were intimately involved in how that was managed, but it undoubtedly disrupted the progression to the internal medicine training quality criteria, which is why we're here some 5 years later as we've been working to try and evolve these criteria, which you should all have a copy of within your pack. These are not to replace the GMC standards. They're there to complement and indeed enhance existing GMC standards. But we are specifically looking at internal medicine at the present time. And what we're looking to do is ensure that the training experience right across the country has quality but consistency. And I think it's fair to say, and recognised by those involved, for instance, in ARCP processes, that over the past few years, having some consistency in ARCP outcomes for a trainee who has an e-portfolio that shows the same level of attainment, they should have the same outcome at ARCP. That has been improving over the last few years, and thanks to Anita Jones and Jane Wallace for pushing forward on that. But we need to ensure that we're looking at the curricular priorities and developing, as I've already said, with a wide range of stakeholders, using the NTS and I'll come back to why the NTS in just a minute, but we are looking to see how this can be reported at a variety of levels, including local education provider and, of course, regionally and indeed nationally. The impact of the quality criteria from CMT was defined and it has been published. There is a fair improvement in a number of parameters over 2015 to 2018, including attendance at post-take ward rounds, including the handovers and outpatient clinics, and we'll come back to outpatient clinics in a little while. But the training opportunities, including bleep-free learning events, the opportunity to attend simulation sessions, curriculum relevant and patients teaching, all improved during the time that these were being monitored by those quality criteria. And pre-ARCP appraisals and plans for attempting MRCP were all shown to be improving. But why the NTS? The National Training Survey, as far as I'm concerned, is the best responding survey that I'm aware of. It used to be up above 90%. The latest is still above 70%. But for those of us that have had to do surveys on a recurring basis, getting better than a 33% response rate is actually pretty good. So 70% is really very good indeed. It's fair to say that doctors, be they trainees or trainers, are naturally slightly competitive, and therefore it is an important tool that we can use to see how well people feel that their training experience is going. And if we're getting such a high response rate, it has extra validity. We have worked with the GMC to develop more specialty-specific questions, and that gives us the additional insight that we need. It's fair to say that the data do show us things already. This is support from educational supervisors, and on the y-axis you can see the grade is compressed a little bit, but you can also see that over 70% during CMT felt that they were getting a good contact from the educational supervisor, but more recently we're down below 58% getting that experience. This is obviously something that's of concern, and how we modify things to try and improve that. There are some things that are actually completely standard and static, and support from clinical supervisors is indeed consistent. But if you look at, again, on the y-axis, that's at a level of 40%. So are these people being used appropriately to become trained, as well as getting a work experience? Now, there is a combination, and the interaction with clinical supervisors is critical in terms of how we actively train people. The use of technology and its availability for some reason seemed to drop off in 2021. I don't know if somebody thought, okay, let's have the Millennium Bug a bit later than it should have been, but doesn't seem to be, because overall that seems to be improving, and there's still something that we can see is available within the workplace, that people do have the ability to access some technology. But in terms of the local education providers providing the curricular requirements, and this is specifically looking at outpatient experience, over the period of time that's increasing. I think it's fair to say back in 2017 people were not getting much experience in terms of outpatient experience, but now that has improved, but still at a level that is suboptimal compared to the curricular requirements. So again, how do we match the opportunities with the curricular requirements? That is just looking at the data in a tabular form, and it will be in your packs. It was the criticism labelled at, or levelled rather, at these criteria was that some are incredibly easy to attain, and others, perhaps more importantly, are difficult to implement. In other words, do we just pick off the low-hanging fruit? And so we did take all the questions that we're now asking to an independent panel to say, what did people think was easy to achieve, and what did they think was the most impactful of the quality criteria? And from that, we had the top 6 weighted scores for impact level and for ease of implementation. And it's interesting that some appear on both sides. But in terms of impact level, quite easy to ensure that everybody's treated fairly. One thinks that should be automatic, but perhaps not. Rota design is thought to be fairly impactful, but also difficult to implement, according to this panel, which included trainers and trainees. Developing confidence, facilities provision, clinical supervision all had big impact, as did infrastructure to support patient care. But that one also was difficult to implement. So are we actually looking at things that we should be weighting more significantly if areas are achieving this? And that could be a development of the quality criteria as we're moving forward. Just to emphasize, as we're looking at these quality criteria, they're not all at the level of a single organization. And that's why there has to be collaboration. For instance, rota design and technology is at the behest of the employers, not infrequently. Whereas the CS and ES roles lie with the deaneries, the local offices, the DMEs. And similarly, learning support, e.g. simulation, can land at the level of the SEBs or the locality. And so it has to be collaborative as we're moving forward, how we can improve the quality and consistency of training. So I'm not suggesting for a minute these quality criteria are the be-all and end-all. They are an aid to help us look to see how well we are training people. It's not the sole mechanism. We've already said this is related to what the GMC are producing in terms of their standards. But the quality and consistency requires further collaboration, and that is something that we'll be discussing today with the assembled congregation and their abilities in providing their opinions. In the future, we'll be looking for quality criteria for other specialties and potentially for trainers who tend to be forgotten, but the NTS for trainers at the moment isn't achieving anywhere near the response rate that the trainees does. That's all I want to say at the moment. That's the introduction, and hopefully that has given you some context as to why we're here and what we're trying to do.